Hello everyone. So let us discuss this case of community-acquired pneumonia. So a 50-year-old man with history of diabetes mellitus and hypertension got admitted to ICU with community-acquired pneumonia. On arrival, he was hypotensive. However, with IV fluid, he responded and not recovering vasopressor. So he is not in shock at this present moment. However, because of his respiratory function decline, he got intubated and a bronchoalveolar lavage done. We saw gram positive cocci in pairs, that means diplococci, and few yeast cells. So now in this case, what are the antibiotics we can give? We have four options. We will discuss what will be the best option. So for community acquired pneumonia, we have to cover two kinds of pathogen. So number one is typical pathogens and atypical pathogens. So in typical pathogens, we have streptopneumonia and Haemophilus influenza. These are the most common pathogen that can cause a typical CAP. And atypical, we have mycoplasma, chlamydia, and also we have legionella. Right. So we have to choose an antibiotic which can cover both typical and atypical. So we have what you call it. We have ceftriaxone, that is a beta lactam, that will cover the typical, and we have azithromycin, that is macrolide, that will cover most of the atypical organisms, right? Both of these activities, that is covering typical and atypical, can be done by fluoroquinolones, right? So either we have to use the combination of beta lactams and macrolides, or we have to use single monotherapy with fluoroquinolones. But what is better? So there has been studies done in which it has been shown that beta lactam and macrolide combinations preferred. It has been shown that they improve the 28 days mortality of the patient then only fluoroquinolones, right? And why to give macrolide combination therapy in these cases? Because of a variety of reasons. One is antibiotic synergy. It synergizes with the action of beta lactams, right? Then we have atypical coverage. Most of the time we cannot diagnose the atypical organism microbiologically, so we have to give empirically all the patient atypical coverage. So macrolide will cover atypical coverage very nicely. Also, the macrolides are immunomodulators. That's the reason why now in COVID most of these antibiotics are used, because they are immunomodulator. They are mainly act against the IL-8 receptors. This pneumolysine that is produced by the pneumococcus is not inhibited by either beta lactams or fluoroquinolones, right? So we have to give a macrolide. So this combination therapy is preferred actually something called drug resistance pathogens. So there are two kinds of drug resistance pathogens. One is MRSA, methicillin resistant staph aureus, another is Pseudomonas, right? So what are the risk factors for DRP? The risk factors are hospitalization more than 2 days in the last 90 days, antibiotic use in last 90 days, immunocompromised patient, past history of MRSA or other drug resistance pathogens, present hospitalization in this time if it is more than 2 days, also if the patient is having devices or requiring dialysis frequently. These are the risk factor for MRSA or Pseudomonas. Our patient is DRP, MRSA or Pseudomonas risk factor. In those cases, we may not give ceftriaxone azithromycin, right? So we have to give something that will cover MRSA and Pseudomonas. So ideally, that is what is given is in the beginning. We can give teicoplanin or vancomycin that will cover for the MRSA. For Pseudomonas, we can start with piptazone, right? Only if the patient is having DRP risk factor. Now coming to our patient in the bowel, it is growing diplococci, that is streptopneumonia. In our case, there is no DRP risk factors, and also the patient is having severe pneumonia because patient is mechanically ventilated and he is in the ICU. So he has to be given IV medication. He has to be given ceftriaxone plus azithromycin for their benefits rather than levofloxacin alone. Levofloxacin also not given in India because of the issues of tuberculosis. We have to save the fluoroquinolones for tuberculosis. So ceftriaxone and azithromycin are the drug of choice in this case, right? Only if DRP is present in our patient, then we will give Tyco and piptazole. It is especially used in hospital acquired pneumonia or ventilator associated pneumonia or healthcare associated pneumonia, right? Also, candida is usually a colonizer, never causes pneumonia unless the patient is prolonged neutropenic and there is some embolic disease like right-sided endocarditis, right? In those situations that it can produce a lung infection. Otherwise, candida is always a colonizer, it never produces pneumonia, right? In this case, our answer will be ceftriaxone plus azithromycin. Thank you.